feel like people are going to start joining now. So now that we're at 12, I'm going to get started. So hello, welcome everybody. My name is Kira O'Neill. I am the Knowledge Translation Coordinator with the Maritime SPOR Support Unit and your host for this afternoon or noontime. If you're not familiar with the MSSU, we are one of 11 SPOR support units across Canada that support and conduct patient-oriented research, and we work in all 3 maritime provinces. Claire, you can go to the next slide. I'd like to start by offering a land acknowledgement that reflects my location here in Dubuktuk or Halifax. So I would like to acknowledge that I am in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which the Mi'kmaq and the Wolastoqiyik people first signed with the British Crown in 1725. We are all treaty people. We also recognize the histories, contributions, and legacies of the African Nova Scotia people who have been here for over 400 years. Some of you may be joining us from other parts of the country, so I invite you to share in the chat where you are joining us from and to take a moment to reflect on the traditional lands where you reside. Before we dive right in, there's just a few housekeeping notes. The first one is that attendees are automatically muted and can't share their video. If you would like to turn your mic and your camera on to ask a question during the Q&A at the end, that's totally fine. Just raise your hand and we will change your setting individually. Just a reminder that a recording is in progress, so this session will be made available after the webinar on our YouTube channel. So we are currently recording. Live captions are also available. So to use live captions in the meeting, you can go to your media controls at the top of the screen, select more actions, language and speech, and then show live captions. If you have any issues with that, Claire is able to help you out in the chat. And finally, we are hoping to save quite a bit of time at the end for a Q&A and discussion. So please use the Q&A box at the top of your screen to ask your questions, and I will kind of moderate those after our guests are done with their presentation. And so without further ado, I'm very pleased to welcome you to the session of the Learning Health Systems in Action webinar series. Claire, you can go to the next slide. Thanks. So the term learning health system, or LHS, can be confusing or maybe new to some. So I want to open with a quick definition. So what is a learning health system? This is one definition from the Agency for Healthcare Research and Quality. So in a learning health system, internal data and experience are systematically integrated with external evidence, and that knowledge is put into practice. As a result, patients get higher quality, safer, more efficient care, and healthcare delivery organizations become better places to work. Claire, you can advance. There's no single definition or model, and you can advance again. But across learning health systems, you will notice a shared focus on generating, integrating, and applying evidence in healthcare to improve outcomes. As a result, the elements of a learning health system are often visualized as a learning cycle. Claire, you can go to the next slide. So this is ours. The graphic is on our website. If you are curious to know more, you can see various components of this cycle feed into each other. So data is generated, integrated with external research and evidence. It's studied to generate new knowledge, and then it's used to improve practice and inform policy and decision making. And the cycle continues. So given our patient-oriented roots, we put communities at the heart, which reflects our values and health system aims with an overarching commitment to equitable healthcare. This is a very flexible model. So for example, this approach could be used by a health authority, networks of facilities, a hospital, or a specific unit. Maybe you recognize aspects of your own work in a learning health system approach, even if it's called something else. that's what this series is all about. So getting to know this cycle. In each webinar, we'll kind of zoom in on an element of the learning cycle and bring it to life with examples of how this can work in practice. So today, we're going to be looking at how community and collaboration are fundamentally involved in learning health systems. The community includes everyone in the learning health system: patients and citizens, clinicians, researchers, administrators, and policymakers. And I'm going to keep the introductions short to save as much time as possible for our guests. Joining us today, we have Dr. Christine Cassidy, who is a registered nurse and associate professor in the School of Nursing at Dalhousie University and clinical scientist at IWK Health. She is the scientific lead of Maritime Child Health and co-director of the Strengthening Transitions in Care Lab. Grace McIntyre is a research assistant with Maritime Child Health and a graduate of DAL's health promotion program. She's a former patient partner and now works on projects related to transitions in care, equity-focused implementation science, and learning health systems. Katie McDonald is a pediatric nurse and manager of Maritime Child Health. She has experience in pediatric care, education, and service planning, and provides leadership to build an integrated and accessible system of pediatric services across the Maritimes. And without further ado, I'm just going to pass it right over to Christine, who's going to get us started.
Great. Thanks so much, Kira, for that excellent lay of the land and introduction. I'm Christine, and I'm thrilled to be joining Katie and Grace today to share a little bit about how they've really been leading some work around building a pediatric learning health system here in the Maritimes with youth, families, clinicians, and community partners. So if you can go to the next slide, please. Just building on Kira's land acknowledgement, I want to share also that, today we'll be talking about learning health systems, which focus a lot on knowledge and that idea of moving knowledge into practice. For myself, when I think of the word knowledge, oftentimes I think only of research evidence, but it's important to acknowledge and reflect on the different types of knowledge and ways of knowing and how that's mobilized and implemented in children's health. So that's something that I'm reflecting on, and I encourage you to do that as well throughout this talk. On the screen here is a quote shared with us recently at our Maritime Child Health Summit by Elder Anne Labilwa, who's an elder in residence at Dalhousie University. And Elder Anne shared that our children are our greatest teachers. My children taught me to listen. This is a great reminder for us that we have so much to learn from each other, and particularly those with lived experience. So this will be the focus of our talk today. Next slide. Just quickly want to mention that we have no conflicts of interest to declare related to the content of this presentation, but also want to mention that Maritime Child Health is funded through the Windsor Foundation and the IWK Foundation's community of donors. And the research study that's shared within this presentation was supported by funding from my Tax Accelerate program. Next slide. So we have three main objectives today. We want to discuss our learning health system approach and the role of implementation science to move theory into action. We'll also explore the initiatives that Maritime Child Health has undertaken to engage a wide range of partners across the Maritimes, and chat a little bit about what's next to advance both the science and practice of Maritime Child Health as a learning health system. So the next slide, another definition about a learning health system. We heard from Kira a great introduction to this concept. In the IWK Health context, we really think about a learning health system connecting data, research, and care for maritime children and families. And by using a learning health system approach, this allows Maritime Child Health to tackle complex challenges facing pediatric care today. So while there's many learning health system frameworks and definitions, this is a shared definition on the screen here of a learning health system that we share with our IWK mental health and addictions colleagues. So keeping that in mind, the next slide offers a couple of additional learning health system frameworks. Kira shared the MSSU one. It was built upon existing frameworks that are available in the literature. There's several different models, frameworks. They all encompass very similar components around this continuous cycle of practice, producing data, which then leads to evidence. It's incorporated with external research evidence, and then that's put back into practice, and that cycle continues. So the next slide was built upon, we found that those models are quite pretty conceptually, they make sense, but our team at the IWK, we were looking at these models and at the literature, and we found that there was lots of literature describing this concept, but we were left quite confused about what does this look like in the real world? How do we actually implement and operationalize a learning health system? So Dr. Murray Somerville, who was a CIHR Health System Impact Fellow with us at the IWK, led this extremely comprehensive mixed methods systematic review with over 5,000 papers initially identified, and 35 papers were included in the review that represented 31 unique learning health systems. The majority of these learning health systems were from the US, and a range of positive outcomes were reported in these papers, including reduced length of stay, improved time to diagnosis. These were some of the more patient and health system level outcomes that were explored. The next slide outlines that, there's many golden nuggets, I think, in this paper, but one thing that we looked at was how learning health systems were described in the literature. So what components of a learning health system are teams and organizations focusing on? So the majority of papers included in our review focused primarily on digital data capture. So they did a really good job of capturing that patient health administrative data that is critical for a learning health system and to advance those cycles. But the components that were most often missing from these papers were patient, community engagement, and this idea of creating a culture of rapid learning and improvement. In my opinion, two of the most important components of a learning health system. Next slide, please. This review also looked at the strategies used to implement learning health systems, so not just the components or pillars of a learning health system, but more about the how it was implemented. We used the ERIC taxonomy of implementation strategies to code some of this work, and the most commonly reported implementation strategy was changing record systems. So again, that key focus on data, which is really important, but missing implementation strategies related to patient engagement and how to create that culture of rapid learning and improvement. Next slide. So building on this concept and what we knew from the literature, we wanted to get a sense of what does this look like in our own context at IWK. So we decided to use a learning health system framework as a way to identify the assets and gaps at the IWK. And our kind of case study that we did this was during the COVID-19 pandemic response. Next slide. I am certain that it's not too hard for everyone to put themselves back to March 2020. We were seeing a range of health system interventions that were being quickly designed, quickly implemented, while significant restrictions were being placed on our social and health systems. And this was a rapid change to a system that we know has been very slow to transform. And as researchers, this was a unique opportunity to explore how are these health systems adapting under rapid and constant change. And so we wanted to know, how was the IWK working as a learning health system in this context? Next slide. So just some really high level findings from this work. We used a triangulation matrix to map both quantitative, so textual and administrative sources, and qualitative data through semi-structured interviews onto the 7 characteristics of a learning health system as defined by Dr. John Lavis and his team. And we did this to try and identify, again, those assets and gaps related to the IWK's health system receptors, as well as research system supports. So again, high level takeaways from this work, first starting off with the importance of engaging patients. During the pandemic response, many of the usual ways of working based on patient and family-centered care were limited, and restrictions we found on family presence doesn't necessarily mean that we need to replace the principles of family-centered care. So moving forward, one of the key findings from this work was, as a learning health system, patients need to be engaged in decision-making, not just in research projects. And so that we'll learn and hear a little bit more from Katie and Grace. Second, around data capture, the health center did the best with what they had, but we know a learning health system will not be realized without adequate digital data capture of the care experience with those patients and families. So we need to be considering that when building a digital infrastructure. Thirdly, this study highlighted that existing health system research structures and partnerships that really aim to support the timely inclusion of evidence in decision-making were not well established. And so in order to be most effective in supporting a learning health system, we need to have researchers and research programs embedded in the health system operations to provide that rapid integration and implementation of evidence into practice and policy. And lastly, this study really suggests that the organization was already implementing many features of a learning health system pre-pandemic. It has the capacity and infrastructure to further develop without, radically altering the way that it functions. And so this study does highlight some of those assets within the organization and what we can leverage, gaps we can address to strengthen the learning health system infrastructure. And I think this work really laid the foundation for what's next, and Katie's going to take over from here, how the IWK can go and move forward as a learning health system. So over to you, Katie. Thanks.
Thanks, Christine. So I'm Katie, as she said, and I'm just going to share a bit about the background of why and how our program came to be. So as you can see on the slide, children, youth, and families access care across a number of organizations, sites, and services in the Maritimes. And in addition to pediatrics, outside of the IWK, many providers are also responsible for labor and delivery, care of neonates, and adult patients as well. And so not all of these access points are created equal, and they are not all resourced for the complexity of healthcare, the healthcare needs of a child. And so some additional context pieces for what it's like to care for pediatric patients across the Maritimes. So it can be difficult to maintain competency in pediatrics due to competing demands and low volumes. There's often high staff turnover and a junior workforce, so leaving very limited opportunities for mentorship. Our IWK resources often lack applicability and adaptability to the rural and regional context. There is an inconsistency when including patient and family voices, and there's a gap between known evidence and bedside care. Often these efforts to incorporate this are done off the side of desks and take a long time to integrate into the bedside, if at all. And we often have gaps in coordinated care and communication. So these realities can lead to inequitable access and poor outcomes. And ultimately, our patient population is the same and often moves throughout our various organizations in our system, but aren't able to get consistent, equitable care. So because of this, we've chosen a learning health system approach for our work. And we often hear that it can take, on average, I think it's 17 years now for known evidence to be integrated into the bedside. And so that's particularly critical to close this gap for our children, as 17 years is their entire childhood. So if that evidence sits and isn't translated, that's an entire childhood of opportunity missed. So next slide. So our program, Maritime Child Health, is a 5-year donor-funded initiative that was established about a year ago. So this program is the result of the vision of passionate pediatric leaders who advocated for funding and support to provide equitable access to care regardless of geographic location or socioeconomic status. Historically, we've collaborated in a more reactive way, so sharing education and resources only when needed, when a sick child requires transfer or immediate care. And so we hope this approach will bring together researchers, clinicians, decision makers, patient partners from across the Maritimes to take a more proactive approach to tackling our shared challenges. Using our local data and experiences to embed best practice is a more sustainable way so that children, youth, and families are supported to access safe and equitable care as close to home as possible. Our program is guided by listening to the expertise of clinicians, researchers, decision makers, community partners, families, and patients, as well as health system data to continuously learn what works best, identify the gaps in care, and take action. And we're dedicated to improving care beyond the walls of the IWK, so particularly focused on building capacity and pediatric competency to support care across our rural and regional sites. So we use 4 pillars to guide our work to ensure that we stay true to our vision. So using the Learning Health System framework, Christine and I mapped this vision onto along with our the framework and distilled it down into these areas of focus. So real-time clinical data, patient-oriented research, knowledge mobilization, and population health advocacy. And then in true commitment to that iterative learning health system process, we wanted to share with you that we're now revisiting these pillars because over the past year, what we've learned is that the pillar approach has sort of been perpetuating the idea of silos and the notion that all of these things are separate, when truly in a learning health system, we're trying to integrate all of these pieces together so that they work together to make more sustainable change. So more to come as we continue to evolve our perspective on this. Next slide. So a bit about our team. So each role was developed with the intention to meet the needs of the program and the population, and each member brings healthcare experience, expertise, and a commitment to their work. As you can see, we have experts in clinical care, data, research, and health systems. We have 2 pediatric nurses and a pharmacist who provide clinical expertise. We have system transformation and decision support roles to provide.
Your audio cut out, Katie.
Oh, can you hear me?
I can hear you okay.
Okay. How much did you miss?
I didn't miss any.
Oh, okay. Apologies if some people missed some things. So we have system transformation and decision support roles to provide strategic and data support. And we partner with Dr. Christine Cassidy and her team of researchers to help us integrate learning health systems and implementation science approaches in our work. And we also have to stay constantly connected with content experts to co-develop or review content, as we are not, and it would be impossible to be the experts in all things pediatrics. And Maritime Child Health is also governed by our advisory committee. So that provides strategic guidance and informed recommendations for our work. And committee membership includes health leaders from across the Maritimes, researchers, and partners. Next slide. So just very briefly, we've already mentioned, but our team requires tremendous support from partnerships. So we just wanted to include this slide to acknowledge many of our partners who are captured here and that we cannot do this work alone. Next slide. And so our model is based on 4 models that you see on your screen. So from the Institute of Medicine, MSSU, Institute for Better Health, and Alberta SPORE. And they all include the learning cycle, but also prominently feature community at the center. And we have adapted this in our own model, which we use to socialize these ideas across our organization and with our partners. And community at the center of the learning health system is what we're going to focus on with our examples today. So a lot of our work falls within the knowledge to policy and practice section of the framework, but this wouldn't be effective without engagement with community. And for this, for us, community really means those patients and families, as well as the healthcare providers providing that care. And for our first year, just because strong partnerships are so critical to the sort of the heart and the success of a learning health system, we really focused on building momentum, engagement, and developing our shared vision to propel the work of Maritime Child Health forward. So next slide. So this slide just identifies a few of the ways that the initiatives that we've undertaken over the last year to engage youth, families, and clinicians and community partners from across Nova Scotia, New Brunswick, and PEI. Next slide. So in our work, engagement and partnership with those with lived experience providing pediatric care in the rural and regional context is needed. Following the successful model of our partners at TREC, so that's Translating Emergency Knowledge for Kids, we have completed site visits in Nova Scotia and PEI in the past year with the intention to go to New Brunswick in this upcoming year. So prior to the visit, we work with site leadership and educators to determine learning needs. We've also completed a needs assessment of healthcare professionals across the Maritimes to understand and prioritize their learning needs. And then during the site visit, our clinical team members provide education on various topics in pediatrics, and we get a chance to learn about their team as well, so we can tailor our resources to their specific context. We want to ensure that the education we're provided is relevant to their team, and so collaborating is key. And in visiting these sites, we've also had the unique opportunity to celebrate and validate the great work that they've been able to accomplish with minimal support and resources. We've identified a number of innovations and practices that we spotlight and share more broadly with other rural and regional sites for adaptation. And we collect data from our site visits to inform and continuously improve. And so, so far, over 88% of our participants indicate that they'll change their practice following our sessions. And overwhelmingly, attendees agree that they are more comfortable and confident caring for their pediatric patients following these sessions. We've also developed a number of evidence-based pediatric resources, and some of the resources have been co-developed with our colleagues throughout the Maritimes to ensure that we're capturing the realities of the regional and rural context in our work. Next slide. And so next is an example of how we learn from our patients, well, really our families and caregivers. So asthma action plans, AAPs, are evidence-based tools that provide individual written instructions to support patients and families in managing asthma symptoms at home. And so most existing AAPs have been developed and validated in larger urban centers, so therefore limiting their applicability to our to other contexts, including our own. So historically, when engaging patients and families, we've really focused on IWK patients and families, and recognizing the users of this resource would be families and caregivers who may never receive care from the IWK, hopefully never have to come. We worked with Nova Scotia Health to engage their families in this work. And so the objective of the project was to create an AAP that reflects current best practices and evidence that's accessible and equitable and inclusive to the children and families across the Maritimes. And so our clinical nurse and pharmacy specialists partnered with Nova Scotia Health Public Engagement, their team to develop and deliver an online survey through Engage for Health to caregivers of children less than 12 years old living with asthma. And doing this engagement was extremely valuable. We learned so much and we've received so much feedback, including responses like, what do I do if I don't have a primary care provider? That's a very real situation for many patients and families across the Maritimes. And so it prompted us to include more information and additional supports in our resources, like contacting 811 and other supports available to them. So having their input and eyes on this before making it available was so valuable to us. And we'll look to expand how we do this and partner at the outset as well in our next over the next year, rather than only providing the opportunity to review once built, but we had to kind of start somewhere. So that's been super helpful for us. And now I'll hand it over to Grace to tell you more about our research study and our summit event.
Thanks so much, Katie. So as we've covered already in the presentation so far, we know that patients, families, and communities are at the heart of a lot of learning health system models. But in practice, we know from evidence in Canada that a lot of emerging learning health systems do not integrate the perspectives of patients and families meaningfully and equitably in their work yet. And so Christine mentioned earlier in the presentation that we have done a systematic mixed methods review of learning health systems. And one of the key findings was that patient engagement is one of the least reported learning health system characteristics in the literature. So there has been an increase in commentaries and review studies looking at this gap for learning health systems, but there's a lot of tools and frameworks that we still need to inform how we actually go about engaging patients and families in the activities of a learning health system. So next slide. So we really wanted to look at the engagement context here at IWK and how patients and families are currently engaged in quality improvement and research activities. So this could inform our work in Maritime Child Health. So we conducted a small qualitative study which aimed to develop a comprehensive understanding of patients and caregivers' needs, values, and perspectives related to engagement in a health equity focused learning health system. So next slide. So this is a lot of information and we don't have a ton of time, but just to highlight, we talked to 5 caregivers, 3 youth, who've all been involved actively at IWK in research teams or in quality improvement initiatives. And the findings from the interviews revealed barriers and enablers from their experience that they wanted to highlight for us to be aware of going forward in our work with Maritime Child Health. And these barriers and enablers fell within 9 domains of the theoretical domains framework, which you can see these 9 icons on the screen. And these spread across the individual level, interpersonal, relationship levels, and then higher organizational level barriers. And so just a couple quotes on the screen to really capture what people spoke to. For example, one says, just the barrier between being like a civilian and not knowing all the research processes and kind of being like thrown in the deep end and a little bit at the beginning. And then another quote says, it's easier for me to participate because I have somewhat like a health literacy or health background. I understand some of the language that is used. And then this person says, the capacity to have space mentally to participate in something, you know, everyone is tired and stressed and milk is $11 a jug. So these are just a couple quotes that highlight what people talked about in our interviews. And really there was an overarching emphasis from participants that equitable engagement in a learning health system should fall at the organizational level to really evaluate and reflect on what our current practices and policies are and how they might perpetuate the exclusion of equity deserving groups. And participants really talked about their lived experience being valued as expertise and how they'd like to be involved in the decision making and really shaping the improvements that we do through the learning health system. And so this has prompted us at Maritime Child Health to reflect a lot on our engagement going forward and our current existing practices to engagement and how we can do things better. So this small study will help to shape an engagement framework for our work at Maritime Child Health. And we've also had the opportunity to share these findings broadly with clinicians and health system leaders who've shared that these really reflect a lot of the challenges they face in their practice trying to engage patients and families. And so we've worked with colleagues at Holland Bloorview and across the country to develop a grant to potentially do some more work on youth and caregiver engagement in learning health systems at a national level. Next slide. So shifting gears a little bit, we wanted to share about our Charting a Course Together Maritime Child Health Summit, which we had in November in Dartmouth. And this brought together over 125 attendees from Nova Scotia, New Brunswick, and PEI with a range of lived experience, clinical research, data, and leadership perspectives from urban and rural settings. And the theme was around charting a course together for child health and youth health in the Maritimes. Next slide. So I know this is a lot. It's busy and you can't probably read any of the text, but we just wanted to show really the energy and excitement that was in the room around this conference and bringing everyone together. We had the opportunity to introduce what Maritime Child Health is and to share our vision. We also had a keynote speaker come from BC who shared about how they have done a child health improvement network in their context and some of the shared challenges that they have with us here in the Maritimes. And then we also had a fireside chat, which allowed people from across the Maritimes to share different innovations that they've implemented and their lessons learned from their success stories working on child health. Next slide. And then again, on our second day, we had a youth and caregiver panel where they spoke about their experiences navigating pediatric care in the Maritimes and being involved in research and quality improvement work. And then Christine shared about how we can really use tools from knowledge mobilization and implementation science to move from theory to practice. And over lunch, we were able to have organizations like SKIP, Ronald McDonald House present so people could connect from across the Maritimes and connect with those resources. Next slide. So we just wanted to pull out one piece from the summit, which I think is really relevant to our presentation here today, from the youth and caregiver panel. I think we all agree this was the most powerful part of the summit, and they talked about the importance of humanizing the data we use in learning health systems. So this quote in the middle says, "Stories are so important. Behind every statistic and number is a human, and behind every human is a story." So this has really shaped our ongoing commitment at Maritime Child Health to integrate storytelling into how we report data going forward, and really weaving in the voices of patients and families into how we use clinical and administrative data in our work. Next slide. And then just another piece from the summit we wanted to highlight. So we had concurrent sessions in both afternoons over the 2 days, where participants were really able to contribute their perspective on needs and priorities for child health in the Maritimes in the areas of interprovincial care escalation, real-time data, and patient-oriented research. And so we know that there's a lot of talk about what learning health systems could or should be, but these sessions were meant to be useful for Maritime Child Health and others to look at how we could actually put Maritime Child Health and the learning health system approach into action in a practical way, and where we should start. So if we can go to the next slide. These sessions were grounded in the Maritime Spore Support Unit Bridge process, which was developed by Dr. Julia Contac, who was the former KT coordinator at MSSU, and Dr. Amy Grant, the MSSU Director of Research, and their colleagues. And this process really outlines 5 steps rooted in integrated knowledge translation to help identify and support collaborative research approaches for priority topics. And so this process helped us shape our approach leading up to the summit, how these concurrent sessions were delivered and facilitated. And then going forward, we'll continue to use this process in terms of how we collaborate with people to action some of those priorities that came out of the summit. Next slide. And then lastly, we just wanted to highlight some of the feedback we had was really positive. People found this opportunity to get together super impactful, because we don't really have anything like this for Maritimes and pediatric care. And so they reported that it was useful to kickstart conversations on how to collaborate on shared priorities. It helped them gain a better understanding of who we are as Maritime Child Health and how they could be involved and participate in advancing our work. And they also spoke about how the summit helped to inspire practice change and to bring back some of the knowledge they gained from the event to their colleagues in regional and rural sites. So this was really a great opportunity for Maritime Child Health in our early phase, in our first year, to identify some of the key action areas we want to carry forward now in our strategic plan. And it was a great opportunity to bring together all the health organizations to kind of develop a shared understanding of what Maritime Child Health is and how we will work together going forward. So on that note, if we go to the next slide, I just want to pass it over to Christine to talk about what's next for us going forward.
Thanks, Grace. So both Katie and Grace have done a really nice job outlining this foundational year for Maritime Child Health and how communities have been engaged to really chart this course together. It's been really timely as Maritime Child Health starts to develop our strategic plan for next steps. And so moving forward, really starting to focus on the other components of a learning health system, including a really strong focus on data capture and integration of that data into our care for children and youth health in the Maritimes. And in addition to these components of a learning health system, we're also working together to advance our own practice and science of learning health systems. So first, building on these components of the learning health system that I described at the outset of this presentation, we're also dedicating efforts to focus more on the process or the steps of learning health system activities and getting that into action. So drawing on the principles of implementation science to support the integration of practice, of evidence into practice and policy, and advancing that culture of rapid change and improvement as a key component of a learning health system. And secondly, what I think is so unique about Maritime Child Health is that it really offers this natural experiment to study real-world learning health system initiatives at multiple different levels. So to Kira's point from earlier on, maybe at a micro team level, all the way up to more of a interprovincial system level. including how does a learning health system approach facilitate that implementation and sustainability of evidence-based interventions. So we're working together to study these initiatives in order to advance our understanding and the science of a learning health system, and really hope to inform learning health system practice beyond our local context here at the IWK. So we're just on the cusp of this, so stay tuned for some exciting work in this area to come. So I think we'll close there. The next slide is our website for additional resources. And I think we will hand it back over to Kira for a question and answer period. Thanks.
Thank you, Christine, Grace, and Katie for that fantastic presentation. I really appreciate how you prioritized engagement to better understand how people are already experiencing engagement in the health system, and how you're using that knowledge as you move forward to ensure that engagement is equitable as you move forward. I think that is a really sort of interesting and wonderful first step. So I'd like to use the time that we have left for questions. A quick reminder to everyone, if you have a question, you can put them in the Q&A box at the top or the chat. Either one is really fine. Or you're welcome to raise your hand and we will allow you to turn your camera and mic on and ask a live question. I think we have one. Oh yeah, we have a couple questions. Great. So the first is, when you did the work to identify learning health system assets and gaps, did you look at the brakes and accelerators which are identified in the John Lavis and Rob Reed LHS framework?
It's a really great question. Not for this particular project. The focus of the administrative data that was collected and the interviews was to understand the experience of the COVID pandemic rapid response. So this particular work was a secondary analysis of that data set using the triangulation matrix. So we really just focused on the assets and gaps of the health system receptor supports and the research system supports. But I feel like that could be another additional lens. I'd love to do a similar study now, now that we're kind of 5 years since we've done that work, to understand how the learning health system infrastructure has grown. The concept of an LHS, when we focused on it in 2021, you know, that those words weren't even known within the health system. And so I think it would be a very interesting follow-up study and to really get at some of those brakes and accelerators, as you've mentioned.
Thank you, Charlene, for that question. As sort of further questions filter in, I have a question. So you talked a lot about engagement, gathering input from different key partners, and you mentioned that there was a lot of excitement. So especially at your summit, people were really engaged and excited to kind of be together and discuss this. So how do you go about managing that excitement around maritime child health, especially if there are maybe competing priorities or needs among your partners?
I can start maybe, and then, yeah. Thanks for that question, Kira. Yeah, there's certainly a lot of excitement and a lot of ideas and things popping up. And actually what we're hearing from our partners is, leaders in a zone in Nova Scotia got together and actually spent time identifying their priorities for pediatrics and then how they were going to move through it. And that was great because I think just as such a small proponent of the population, like that wasn't really happening, right? They're in an adult system with lots of pressures. And so that was exciting to hear. We are spending some time looking at a process for how we prioritize and how sort of requests come in and how we move through that, and making sure that we have an approach to prioritizing. Because in our first year, it was like, who wants to work with us? This is great. Anything goes, right? But we're trying to be more intentional with that. And so it's not this like, let's try to boil the ocean kind of approach. And also realizing we have to be responsive and kind of lean in where system priorities are going, or where there might be some government priorities, or there might be a current need. So kind of keeping that flexibility. And and capitalizing when people seem ready to do some work on things. So we're doing that. And then I also think recognizing that we're not the only ones who can do this work. And so, for instance, one of our nurses is a co-funded position with SKIP, Solution for Kids in Pain, and so focusing on implementing the pediatric pain standard. And so there was an opportunity to submit a research grant focused on pain priority needs, and we had a community partner network, People in Pain Network that was interested, and then some other Nova Scotia researchers from a number of Nova Scotia universities. And so we were able to kind of bring everyone together to and dedicate some resource to help crafting that idea and putting the work together. But then we're not going to be the only ones doing that work, right? So it's also giving people a place to reach out and share an idea and say, who do we need and what would we need to move this forward? But we may not be the ones doing it, which I think is really exciting. So long answer, no set. There's no one way, but I think that's okay, right? And it's just trying to kind of move through everything and realizing where the opportunities are to move the work forward.
Yeah, the sort of the flexibility, being adaptable, and sort of, maybe offering like a knowledge, being a knowledge broker, connecting people to information, other people that are doing the work that you may not sort of be able to do yourself. I think that's really important. We have a question from Sam, who says, thanks for an interesting presentation. What political, i.e. accountability, and or structural, i.e. interoperability and data sharing barriers to a learning health system have you encountered in your work, if any? So political, structural barriers.
Yeah, I could start with that one too.
Do you want to start? Yeah, and then I'd love to jump in.
Yeah. So many. Probably be easier just to list the facilitators. No, but
where you don't have barriers.
Yeah. No. What we've realized is, I mean, we had our old systems, right? We're just moving into this new place in Nova Scotia with an electronic health record, but our other provinces don't necessarily have the same, or, so we really, there's not a lot to start with. And so it's even just starting those conversations about what other provinces and health organizations are collecting, what would be asking our providers and our patients and families, like what would be most meaningful to you for us to collect. And so we're very early on in that, but naively, I'm a nurse, full disclosure. So I was like, yeah, we just need some people to kind of really dig into this and figure out what's already existing and what other health centers are doing. While there is great work, there's still lots to kind of figure out. And what we've also learned is lots of places now have these electronic health records and these kind of big mines or repositories of data, but then but there's not much happening with them. So I think it's an opportunity for us all to kind of learn together as well and how best to move forward with this. But yeah, Christine, I don't know if you have anything you want to add.
Yeah, no, definitely the data piece. I think, there's some great examples even within the broader IWK Health organization, like the reproductive care program.
Yes.
IWK Mental Health and Addictions is doing some really great work with data. So we've got some great partners and role models. It's just in the pediatric space that hasn't existed until there's been some more dedicated efforts now. So I think that's a real opportunity for Maritime Child Health to kind of chart that course in the data piece. When it comes to like the political, I really see this as an asset. I think the kind of throughout the leadership levels, there's a real strength and support of a learning health system approach. And so I think Maritime Child Health has been really intentional and strategic about bringing the right people to the table with different hats and different expertise, including patients and families and healthcare providers. So I'm seeing that as a strength that can kind of push forward with Maritime Child Health becoming a learning health system to its fullest. I think if anything from this presentation, take away that we're just at the beginning and that there's lots of pieces to come to really start those kind of action cycles and rapid change and improvement. So I think some barriers, but also some assets that we can leverage.
Great.
The other thing I was going to add, Kira, though, also is like for us right now too, with the absence of and I won't say absence because sometimes like our old system was really good at counting like the number of patients, but with things like free text and or handwritten notes and things, it's really hard to pull out specifics. But so we are working through that, but also the power, we're trying to embrace the power of lived experience and storytelling and helping to folks to understand impact and in the what's occurring in the current system and then how our work is making an impact. So also thinking about data in other ways rather than that sort of traditional way that we kind of think about it is something that we're trying to do as well.
Yeah, I love your emphasis on storytelling. I think that's so important. It really allows people to sort of connect with this and see it in, a different light or, just puts a new lens on things. So I think that's really, really important. We have not a question, but a comment. So loving Maritime Child Health's initial and ongoing work. In my provincial pediatric liaison role, I can vouch for the relevance of the work outlined here. I have obtained similar feedback from clinicians, patients, and families. I'm developing similar resources and have conducted similar research on a smaller scale. Glad to see some added and broader work in progress to support pediatric care outside the IWK. So just some props to you there. No other questions in the chat, but I have sort of another question that I'm kind of interested in. You, because you have focused so much on engagement, I imagine you've learned a lot about engagement along the way. So like, what have you learned about engaging with different voices? Did you face any kind of specific challenges in that engagement process?
You want to start, Katie, and talk about the clinic? Yeah.
I was going to say you can go ahead and then I can add. I feel like I've been talking a lot, but yeah, there's lots.
Yeah. Well, so I think we've had a couple different groups we've been trying to build relationships with, and the patient and family partnership piece of the learning health system is really important to us, and we want to do it intentionally. So that's sort of why we took this first year to figure out what those barriers and enablers are so we can have a better plan going forward. We're trying, at IWK, we have an engagement team internally, but because Maritime Child Health is across Nova Scotia, New Brunswick, and PEI, we're really trying to figure out the best approach to engage those different communities. And so partnering with the Nova Scotia Health Engagement Team, learning from New Brunswick and PEI in terms of what their engagement landscape looks like. So this first year has really been about kind of figuring out how we go about a maritime lens to partnering with patients and families and supporting the IWK internal team as they work through their policy for how we can do engagement better. And then at a clinician level, I think, Katie, you can talk more to this, but I think going to each site has really helped to bridge that gap because we've been able to go in person, spend dedicated time with people. People come in on their days off because of their excitement around Maritime Child Health, and that's helped to build some relationships, which has kept the engagement consistent over time. So when we reach out, people are responsive, and so I think that's been really helpful with building connections beyond our tertiary site here in Halifax. And I'll pass it to Katie if there's anything you want to add.
No, I think you captured it, Grace. And I just think it's just really highlighted how much, which we knew, but just really highlighted like how much work there is to be done in intentionally and meaningfully engaging folks. And so just continuing to try to learn as much as we can and then also champion it in other settings as we can, just the importance of doing it and doing it well. And not just continuing to go back to the well or go back to the same people and then not going back and kind of showing what's been done with it is important. So, yeah.
And I'll just add, sorry, Kara, just one thing. In planning for our sort of years to come and looking at how we want to go about engagement, one of the things we've identified is a lot of people engage with research teams and in projects within the IWK, and it's those same people, as Katie just mentioned, over and over who are tapped to have their voices contribute. So we'd really like to go more out to community and build relationships in community so that we can bring some of the equity deserving voices that normally aren't included in the healthcare system improvement work into Maritime Child Health. And so we'd like to do that as soon as possible, but we know that that relationship building takes time and intentionality. So we're trying to plan it out thoughtfully for the next few years.
Yeah. I'm just thinking about sort of, engaging different, I don't know, different perspectives. Do you have any plans to engage with the education system at all, or teachers, just because children spend so much time being cared for by their teachers? Like, they're such an important sort of figure in their lives as they grow up. And I feel like potentially those people would have an interesting perspective on children, especially, children who are having to have, managing health and also accessing education at the same time. Is that something that you've sort of, I don't know, thought about, or do you see it fitting in here at all?
Yeah, I would say for sure. We're still a very small team and relatively new, so we had to kind of start somewhere. And we knew in
Yeah.
order to kind of get into some of these communities and understand the context, the health teams at those rural and regional sites would be a place to start. So that's where we've really been focusing. But we also know this has such potential from a population health advocacy
Yeah.
perspective, and just how we can share with the public, government partners on and support others that have been doing great work in the needs of a child in the maritime context. And so I think for sure, I think we also know all of, like, just that the way our systems are set up is that education and health are so separate, but really they're not, and it needs to be considered in a sort of more fulsome way. So yes, I think there's lots of opportunity there. And we have started working with primary care providers. That's not, we're not in the school setting yet, but beyond just that, pediatricians or people who are so focused on pediatric care, working with primary care providers on their providing supports or education and resources on everything that's out there for care of pediatric patients. And I think that's giving us lots of insights as well. So would love to do that. And I hope we get there. And yeah, I think it would be really valuable.
Yeah. Okay, we don't have any more questions coming up in the chat. So I just want to thank you again so much for being here today. Oh, maybe one. We have maybe one last one. Let's see what it says. Has there been any interest or even work done in the area of eating disorders, particularly around early intervention, first 3 years of symptom onset? Thanks for your work. Kind of a specific question.
Yeah, so we this is also highlighted that how much we think of or I will say, I won't speak for the whole system, but kind of growing up in the IWK system in my career, we have 3 distinct programs: Women's Gender Diverse and Newborn Care Program, Children's Health Program, and Mental Health and Addictions Program. And so even in the beginnings of this work, it was like, oh, the neonate, right? What do we consider? When do they become a child? Maritime Child Health versus Reproductive Care Program, and all of these pieces. Similarly, mental health and addictions is one of those things, because of course we want to consider the full human experience of the child and not just physical versus mental health. And so we've started working with our mental health and addictions colleagues, and we'll be doing some engagement work with, to start, the providers in the rural and regional context, similar to our first needs assessment, but around mental health and addictions education support needs. And so we'll be doing that coming up to kind of set some priorities. We have connected. So I chair a group called the Pediatric Operations Group, and it's pediatricians from across the Maritimes coming together on a regular basis to talk about the priorities or the needs of the population. And so we have had the IWK eating disorders team come to that group and present and connect and sort of build those connections. I think lots more work to come, but it has started, which is great. And recognizing, like, again, that's another one of those examples where we're not going to be the experts on that, but there's great work happening and great experts that we can be that connector, right, to those providing the care to those with the expertise. So
Great.
yeah.
Okay, because we're coming right up on 1 o'clock, I just wanted to see if there were any kind of final closing thoughts that any of you wanted to share before we sign off for the day. No, I
Thank
think
you so much for giving us this opportunity.
Well, we appreciate you being here so much. So thank you
Yeah.
for coming and sharing, this incredibly important work. So we will be sending out an email with a link to a short evaluation survey. So please share your thoughts on this webinar, any ideas for future presentations, and we will also be sharing a link to the recording after the session. So thank you all very much for being here today. Thank you, Christine, Grace, Katie. It was wonderful to have you.
Thanks, everyone.
And
Thank you.
I hope you all have a great rest of your day.
You too.
Bye.
Thanks, Kara. Bye.
Bye-bye.